Sir, please start. Sami sir.
Hello,
Yes, sir.
am I audible now?
Yes, sir. Yes, sir.
And my slides are visible now?
Yes, sir.
Okay. So welcome to the third episode of MahaAP subspecialty. For this year, we have started the MahaAP subspecialty from last 2 years. Now this year under the Dr. R.D. Patil sir, President, and Dr. Abol Pawar sir, Secretary over the Maharashtra IAP, MahaIAP. We are continuing with this session of MahaIAP subspecialty, and today we will talk about the nephrology. And in the nephrology, we have nephrotic syndrome. We are talking about this today. So with me, we have Dr. Sachin Numre sir. Sir, will you please introduce the today's speakers? Please unmute yourself first.
I would like to thank MahaAP first, and I would like to introduce today's two eminent speakers. First is Dr. Pankaj Bhansali from Sambhaji Nagar. Sir has done his MD Pediatrics and he is a fellow from Wadia Children's Hospital and St. John's Medical College, Bangalore. Right now, he is consultant at Orchid Pediatric Super Speciality, MGM Medical College, Kamal Nayan Bajaj, and Sigma Hospital at Sambhaji Nagar.
Okay, we have with us with Dr. Kiran Sate sir also.
Yes, sir. So can you put the slide?
Yeah, 1 second. Can you see now?
No, sir.
Okay, I will introduce Dr. Kiran Sate sir. Dr. Kiran Sate sir is a consultant pediatric nephrologist at HN Reliance Hospital, and he has done his fellowships from the Vijay Wadia Children's Hospital. And today, combine of both of the Dr. Pankaj and Dr. Kiran Sate will talk to you about the nephrotic syndrome, each and everything regarding this. We are also thankful to all our subcommittee members that includes Dr. Pallavi, Dr. Neha Singh, Dr. Jadhav sir, Dr. Sachin Patil sir, and with us for today we have the MMC observer, Dr. Sandeep Kadu sir. He is attached to the MUHS and he is a forensic expert from the MUHS Nasik. So thanks to the all audience today here, and we'll ask to share Dr. Pankaj and Dr. Sate sir to start continuing with the live stream for now. Dr. Pankaj sir.
Yeah, Kiran.
Please start your screen.
Yes, sir. Kiran.
Yeah, just read it. Is it visible?
Coming up.
Are you able to see the presentation?
It's blank slide.
Just a minute. Yeah.
Till the slides gets open, I will request all the audience here to join with the Zoom, but Zoom link is finished with 100 participants. So please join with us with the MahaIAP. You add the word MahaIAP on the YouTube and you can see the current session live there.
Yeah, Dr. Pankaj, I think, is it visible now? The presentation?
Screen is not visible, sir.
No, sir.
You share
Presentation
the
is
screen.
not visible. Sir, just make your presentation full screen and then click on the share screen button.
Is it
Hello?
visible now? Okay.
Please open your screen, PPT first. Please open it first and then start share screen. Dr. Pankaj, yes.
Sir, minimize your Zoom screen first. Open the presentation.
Okay.
If the presentation is open, then open the Zoom window.
Yeah. Is
Yes,
it
sir.
seen?
Yes, sir. Yes, sir. It's coming. Yes, sir. It's full screen now. Thank you.
Just a minute. I'll just go to the first. No,
Yes,
just
sir.
go
You
to
can
the
make it
first.
full screen.
Just a
It is
minute.
full screen, sir.
It's
Yeah,
full
yeah.
screen.
Samir, sir, it's
Yeah.
already full screen.
Okay, now it's
Can you see it now? Is
Yes,
it
sir.
Yeah,
seen?
Yes,
Yes.
sir.
Okay. Yeah. Sorry, Dr. Pankaj, you
Thank you.
can start.
Yeah. Good evening, everybody. Thank you, Maha IAP, and special thanks to Samir, Dr. Samir and Dr. Nune for giving us opportunity to be here on this platform. We'll start with the today's topic, that is nephrotic syndrome. This topic we are dividing between both of us, and we'll little more interactive, and we'll have almost 20 minute session from all of us in 3 to 4 sessions. Next slide. Next. So I'll first cover how do you suspect, how do you diagnose, and how do you treat first episode of nephrotic syndrome. Next.
पंकज थोड़ा loud आवाज चाहिए थोड़ा सा. Sound should be big.
Okay. I'm starting with a 3-year-old boy who presented with fever, body ache, and on examination, child has edema, blood pressure was normal, and urine examination revealed albumin 3+, RBCs nil, and pus cells 1 to 2. So is it nephrotic syndrome? Are we sure is it nephrotic syndrome? And so presence of just proteinuria 3+ doesn't equate to nephrotic syndrome. So as we know, nephrotic syndrome has 3 features. One, edema. It should be associated with significant proteinuria. In urine routine, 3+ or 4+ is labeled as significant, and we quantify for 24-hour urinary protein. More than 40 milligram per meter square is significant. But as we know, in pediatric, particularly in child less than 2 years, 24-hour collection will be difficult. So urine protein creatinine ratio more than 2 is labeled as significant proteinuria. But along with that, we also need to have hypoalbuminemia. Now, creatinine should be always normal whenever we are labeling child as a nephrotic syndrome, because when you say nephrotic syndrome in pediatric, the first differential, second differential, and third differential will be minimal change disease, and creatinine will be always normal in minimal change disease. Hypercholesterolemia is associated in most of the patients. So before starting steroid, we shall be sure of the diagnosis. Now, the annual incidence of nephrotic syndrome is around 2 to 10 cases per lakh children below 18 years of age. It is more common in 2 to 3 years of age. Almost 50% age group will be 1 to 4 year, while less than 10 year will have 75%. So about 10 year, it is relatively uncommon below 18 months of age. And prevalence is around 16 cases per 1 lakh. And the most important thing in nephrotic and most troublesome thing to manage, it has relapsing course. Next. Now, steroid sensitivity. The most important factor which decides long-term outcome of the patient with nephrotic syndrome is steroid responsiveness. Irrespective of all other biochemical markers, clinical markers, the most important is steroid sensitivity. And all kids who are responding to steroid, the risk of progressing to CKD is very minimal, almost less than 1 to 3%. While if we consider steroid resistant group, almost 30 to 50% have a high risk to progress into chronic kidney disease. So the factor which decides long-term outcome is steroid sensitivity, even more important factor than biopsy finding. Next. Histopathologically, minimal change disease is the commonest form, followed by FSGS, mesengoproliferative, and then rare formalities of glomerulopathy, that is membranous and membranoproliferative. But if we go towards adolescent age, the incidence of minimal change drops down and the other diseases increases in incident. Next. So when shall we clinically label it as a minimal change disease? In a case of nephrotic syndrome, if age of child is more than 1 year and there is no gross hematuria, theoretically, yes, few kids can have gross hematuria, but practically when we see gross hematuria, child needs further referral and even biopsy. there should not be persistent hypertension or microscopic hematuria. What do we mean by persistent? That means during initial phase, child may have mild hypertension as well as microscopic hematuria. But over the period with treatment of nephrotic syndrome, microscopic hematuria and hypertension should resolve. If it persists, again, it is an indication for kidney biopsy. And we don't expect any systemic features. So if child presents along with nephrotic syndrome, rash, arthralgia, prolonged fever, any cardiac involvement, think of systemic diseases like SLE, HSP, and other systemic onset nephrotic syndrome. So any of these features should warrant further referral, and creatinine always needs to be normal. So these are features of minimal change disease. And if we see all these features in our patient, we can start with prednisolone without much hesitations. Next. So the list of the features which I have explained in previous slide, if we differ from that, this is an immediate indication to referral, because all these kids will require biopsy before starting steroid. Because unless we biopsy, we won't be able to judge what is the prognosis of this child and how long steroid we need, and at what time we need other agents who works as a steroid sparing agents. Next. So any other investigation do we need before starting prednisolone? Mantoux test. Yes, whenever we are considering long-term steroid, whether it is nephrotic syndrome or any other systemic disease, we need to rule out tuberculosis. And the test which we recommend is Mantoux test. Do we see any wrong interpretation of Mantoux test in this photo? Yes, because the slide should have been vertical rather than horizontal, because we measure induration in horizontal, like not in the axis of limb, it should be in the transverse direction. So Mantoux test is mandatory. If Mantoux test is positive, then we need to screen for tuberculosis, which needs X-ray chest, sometimes gastric lavage, and the further investigation. Because if Mantoux comes positive, treatment of tuberculosis takes priority over treatment of nephrotic syndrome. In simple words, what we used to utter, that nephrotic rarely kills patient, and what can really kill patient are infections. So nephrotic, even if child is bloated, treatment of infection take precedence over starting steroid. So we need to start on AKT, wait for 2 weeks before starting prednisolone. Generally, we assume that in 2 weeks, there will be bacterial clearance. So wait for 2 weeks and then start on prednisolone. Sonography abdomen is not mandatory because ascites does not require sonography to diagnose it. So USG does not come as a mandatory investigation in nephrotic syndrome. C3, C4, HIV, HbSAg, these investigations are required only if we see any atypical features. So Mantoux, other than Mantoux, this list does not require to start steroid. Next. Now the treatment of first episode, it has been listed since so many years, but still many of the time it is not given adequately. And it is very important to treat first episode aggressively and adequately, because many of the studies have proven beyond doubt, if first episode is not treated adequately, the risk of frequent relapses, dependent course, and poor long-term outcome is there. So first episode start with 60 milligram per meter square or 2 milligram per kg per day. We'll give it for 6 weeks, confirm remission, and after 6 weeks, shift it to 1.5 milligram per kg alternate day, again for 6 weeks. So that means total duration of course is 3 months. After that, we can stop it abruptly, or we can taper out in next 1 month. So first episode, 3 months course is mandatory. Even if we see Cushingoid features, even if we encounter drug-induced hypertension, the course should not be shortened. The treatment of hypertension can be given with starting enalapril, but course should be continued for 3 months for first episode. Next. Next.
Yeah, that's relapse, no? Yeah, okay.
I think one slide is missing.
Okay.
Yeah, relapse. Okay. So, but when during relapse period, the prednisolone course is for shorter duration, that initially will give same dose, that is 60 milligram per meter square or 2 milligram per kg, till remission is induced. Generally, we expect induction of remission in 10 to 14 days. And after that, we can shift to 1.5 milligram per kg alternate day for 1 month. And in this scenario, tapering is not required. Now, when we shift to alternate day, whether it's a first episode or relapse, ensure that we give it as a single morning dose. We should not split the dosage. When we are giving on daily dose, then we can give as a single dose, but we see a lot of patients coming up with gastritis following single morning dose. So we can use divided doses, but alternate day should always be single morning dose. Otherwise, the purpose and rationale of shifting it alternate day will not be served. What we are doing it alternate day as a single morning dose so that hypothalamic pituitary axis suppression will not be significant. So alternate day should be always on single morning dose. Next. Now, if child lands up in some other specialty beyond pediatrics, we see list of other drugs on the prescription, which includes H2 blocker, antacids, ACE inhibitor, calcium supplement, and even prophylactic antibiotic. Do we really need these medications? To answer to that, all these medicines is no. We know we don't need H2 blocker or antacid unless child presents with symptoms of gastritis. ACE inhibitor only when child presents with hypertension, and this remains drug of choice in nephrotic syndrome with hypertension. Calcium supplements only if we are giving steroid for more than 3 months and there is no role of prophylactic antibiotic. Salt diet, we all know there should be no added salt rather than salt restriction, because we do see a lot of patients where it has been emphasized so much that parents practically stop salt and they consider preventing salt intake will cure the disease. So let us not give punishment for our kid of nephrotic syndrome by stopping all salt altogether. And there is no restriction for his routine physical activity or school activities. Next. How do we monitor? The most important thing is urine albumin test. It can be done by heat coagulation. Yes, many of the centers do practice, but I think with availability of heuristics, which does not cost much, I think the gas which we burn for heat coagulation, that will be sufficient to buy heuristics. And heuristics is easy to do, immediately report is available. But important is monitoring. Every child of nephrotic syndrome, when present for follow-up, blood pressure recording is mandatory. Next. In lab parameters, other than urine albumin estimation, we don't need to repeat albumin or cholesterol to confirm whether they has returned back to normal. Once proteinuria has resolved, we will assume that rest of the parameters will obviously come back to normal. So no role of repeating KFT and serum albumin cholesterol on following up of nephrotic syndrome. Next. And this is the most difficult part of the treatment, that is counseling. While counseling, we assume that we are very clear in our thoughts and we have made it everything clear to the parents. But first of all, parents are in shock that their kid is suffering from nephrotic syndrome, which is a kidney disease. And whenever we see kidney disease, they think of CRF. And we continue our counseling. At the end, it's all jumble in their mind. So it is very mandatory that we may need to reconcile after some day, maybe on next follow-up, to understand how much they have recognized and understood what we have counseled to them. Because if we don't counsel properly, they will keep on wandering to another consultants. So it is not question about losing patients. They will keep on other specialties, other modalities, and end up creating more complication than help to our kid. So counseling remains very important part of our disease. Next. And again, this is important during counseling. The parents need to understand and differentiate what is edema and what is Cushingoid feature, because they don't differentiate it unless we tell them specifically, because sometimes they continue using diuretics even for Cushingoid feature, which is not going to resolve by our diuretic, rather going to create more problem. So periorbital puffiness versus Cushingoid features should be explained thoroughly to the parents so that they don't miss they don't miss the relapse, and at the same time, they don't stop drug suspecting Cushingoid feature is not adequate because of drug toxicity. So both these things should be properly explained to the parents before we discharge the child. Next. So when do we label remission? When urine albumin nil or trace. 1+ urine albumin is not remission it should be nil or trace, or PCR if we have done should be less than 0.2 for 3 consecutive. So urine albumin trace or nil for 3 consecutive days, or PCR less than 0.2. And relapse is when child was in remission and then presents with proteinuria 3+ or 4+. So if urine albumin is 2+, don't start immediately steroid. Assess for infection, treat that infection, and reassess before starting steroid. Next.
So, shall I take over, Dr. Pankaj?
Yes, yeah, cut it.
So, thanks, Dr. Pankaj, for setting the stage for the next part of the discussion. And
Kiran, please थोड़ा sound loud कीजिए आपका.
Yeah. So, nephrotic syndrome, as we all know, is a common condition, and most pediatricians will encounter nephrotic syndrome in their office practice. And we also know that this is a relapsing condition. So, once a child is diagnosed with nephrotic syndrome, there are bound to be multiple relapses. And during these relapses, there are bound to be multiple complications. So, it is important to be aware of all these complications that a child with nephrotic syndrome may present with. So, any child who presents with nephrotic syndrome, in our office practice, it is important to take care of all the basic history that the child may present with. The important points in the history should be detailed history about the edema, since when it has begun, and the extent of the edema.
Can I interrupt 1 minute?
Yeah, sure. Yes.
As in timetable, your topic is etiopathogenesis, clinical features, and nephrotic syndrome. And complication in nephrotic syndrome is Dr. Sachin Patil.
सर थोड़ा प्रोग्राम चेंज हुआ है सर इसमें. He will present the first about the complications.
The timing is 6. Why it is postponed to 9?
So shall we begin? We are going to basically cover all the aspects of nephrotic syndrome in this presentation. There is a slight rearrangement of the sequence, but everything would be covered. So shall we proceed?
Yes, sir. Please.
Yeah. So any child who presents with nephrotic syndrome, as a part of history, the important points to be noted are the history about the edema, the history of atypical features. For example, a very young child, less than 1 year, who presents with nephrotic syndrome, or a child who presents with gross hematuria, even with a nephrotic range proteinuria. Detailed history of the possible complications. The child may present with edema. There may be a hypovolemia, so those symptoms need to be taken care of. Child may have hypertension, infections, deep venous thrombosis. So these points in the history have to be noted. You have to also screen for the history for the possible secondary causes, like a child who comes with weight loss, fever, any joint pains, arthralgia, rashes. So these could be the pointers to the secondary causes of nephrotic syndrome. Any signs, symptoms of toxicity, hair loss, photosensitivity, and the other aspects like immunization status. So what vaccines the child has taken, because infections is a major complication in nephrotic syndrome. And if the child is not adequately immunized about the common infections, that may be an important aspect to be covered. When we examine the child of nephrotic syndrome, it has to be, the growth has to be assessed, the height, weight, the blood pressure, and the serial anthropometry has to be seen. If the child is already developing signs of steroid toxicity, you would also note the vital parameters to see if the child has got any hypovolemia or hypertension. You would evaluate the edema, look for the blood pressure, look for possible complications like edema, hypovolemia, infections, and look for the secondary causes on the examination as well, like the joint examination, skin examination, and look for any organomegaly and jaundice. So the aims of the initial treatment are basically to rule out any infection, because as we know, we would be starting these children on steroids, and steroids are immunosuppressive agents. And if there is an active infection, the infection needs to be treated first before starting steroids. You have to also assess the volume status of the child. And if there is a child who has got severe hypovolemia, then you have to give adequate fluids to the child so as to treat him for the hypovolemia and prevent further complications. Then you have to make a judicious decision whether the child requires a diuretics or not. And all children with nephrotics need not be on diuretics. Diuretics have to be used only for specific purposes and only in a selected situations. So that should be the thing that should be noted. You have to control the edema. Usually the edema would be controlled once you start the child on steroids, and unnecessary diuretic usage should be minimized as far as possible. Then after ruling out all the risk factors, we would start the child on steroids, and the aim would be to achieve a remission as far as possible. Now, as we know that the nephrotic syndrome is a relapsing condition, and there could be multiple complications that could arise, especially because the disease is a very long course disease, and the complications could be classified into complications that arise because of the disease per se, and the complications that arise due to the treatment. So the disease causing complications could be broadly classified as severe edema. There could be infections of the different nature, peritonitis, cellulitis, pneumonia. The child may have hypoperfusion, hypovolemia, which can lead to further complications due to the organ ischemia. There could be venous thromboembolism if a child comes with hypoperfusion and if he's given diuretics and presents with any gastroenteritis. And last but not the least, there could be progressive kidney damage because of the persistent proteinuria. So a child who is not adequately controlled, the proteinuria is not adequately controlled, then this continuous proteinuria is ultimately going to damage the kidneys. Then the second set of complications could be because of the treatment. The different drugs that the child is started on, for example, steroids itself is a big group which has a lot of complications that we all know. And if we don't pay attention to the steroid toxicity, then the child may have problems related to that. There could be problems due to the diuretics, which often cause dyselectrolytemias, and it can also lead to acute kidney injury, like a pre-renal acute kidney injury, and it can also result in thrombosis if it is given in a child who is hypovolemic. Other immunosuppressive medications, as Dr. Pankaj would subsequently talk, those which are given for frequent relapsers or steroid-dependent or steroid-resistant nephrotic syndromes. So these immunosuppressive medications have also their own set of problems in the form of infections, organ toxicities, and even cosmetic side effects. So whenever we find any complication in a child, we have to pay attention to all these different causes that may be causing these complications. Now, a child with nephrotic syndrome may require hospitalization rarely, but they may be for different reasons. It may be for severe edema, which may cause respiratory distress, massive ascites, which may cause this discomfort to the child. There could be a genital edema, inability to ambulate. There could be impaired renal function because of different reasons, infection, thrombosis, and even symptomatic hypertension. So these could be the broad categories of the reasons for hospitalization. Now coming to the first and a common complication, that is a steroid toxicity. As we all know, the gold standard for treating nephrotic syndrome is steroids. And as we would also see subsequently that steroids need to be given for a prolonged period of time. And if a child develops multiple relapses, then he's going to be on steroids for even a prolonged period of time. And every time when the child is on steroids, it is going to lead to certain problems. So this is a common scenario. A 3-year-old boy with steroid-sensitive nephrotic syndrome comes with a presentation of multiple relapses. So in first year itself, he has got almost 4 to 5 relapses. And each time he is given steroids, he responds to steroids, the proteinuria completely stops. But then again, he develops a relapse after some viral infection. So this is a common story in nephrotic syndromes. And these children need to be assessed carefully for the growth in the form of a growth chart. And as we could see here, there is a faltering of the growth on a serial monitoring. We find that the growth is crossing the standard deviations and it is faltering. And this child definitely has signs of steroid toxicity in the form of a short stature. When we examine his eyes, he also has a faint posterior subcapsular cataract. And when we record his blood pressure, we find that the blood pressure is also elevated. So there are more than 1 or 2 signs of steroid toxicity. And this is a child who needs steroid sparing agents. So now steroid toxicity is, I think, the eye examination becomes an important part of evaluation of children with nephrotic syndrome. And at least once 6 months or once in a year, the eyes need to be evaluated for those children who continue to be on steroids. Hypertension is another complication in nephrotic syndrome. And it's usually seen in those children who are frequent relapsers or steroid dependent and continue to be on steroids for a prolonged period of time. The hypertension results from usually steroid sodium retention, and this requires salt restriction. That is the most important measure to avoid hypertension. And those children who develop hypertension definitely require some steroid sparing agents, because that is the only way to avoid the hypertension resulting from steroids. Very often we find that these children who are very hypertensive suddenly may come with a bout of unconsciousness or a convulsion. And when we do a neuroimaging, this may be the presentation that we may find on the MRI. This is called the posterior reversible encephalopathy syndrome. And it is usually a reversible condition. Once you treat the hypertension and you bring it down in a controlled manner, the press or the encephalopathy usually reverses completely and there are no long-term sequelae. In a common study, we find that whenever there is a pool of patients with steroid-sensitive nephrotic syndrome, we would find that steroid toxicity is found almost in 60% cases. And most of these children have a very early onset of disease presentation before 2 to 3 years of age. And as a result, they continue to be having multiple relapses and continue to getting steroids very often. Most of these children will have steroid-dependent or frequent relapsing pattern. And almost 50% children may develop hypertension. And almost equal proportion of patients may develop short stature, obesity, and signs of other steroid toxicity in the form of cataracts. So these are all the potential complications that you need to screen these children for and take the appropriate measures to prevent the further complications. So the prednisolone side effects, I think most of us are aware. Apart from causing increased weight gain, it can cause cosmetic disfigurement. It can cause mood changes, headaches, hypertension. It can lead to striae, myopathy, muscle loss. It can lead to cataracts, glaucoma, glucose intolerance. It can lead to infections, growth impairment, and even certain rare complications like raised intracranial pressure. Now coming to the disease-related complications, so we would see some case scenarios. The first is that of a hypovolemia, which is a very common and an important presentation that one should pay attention to. So this is a 3-year-old boy who presents with a steroid-sensitive nephrotic syndrome, has a relapse with a 4+ proteinuria, and has generalized edema and has a history of vomiting and loose motions. When we examine the child has a tachycardia, the capillary refill time is slightly prolonged. The pulse volume is also of a low volume nature, and the child otherwise doesn't have fever, doesn't appear sick, but definitely seems to be having a low volume pulse and a hypovolemia. The abdomen is also distended and doesn't have signs of infection or any tenderness. So hypovolemia is a feature which is common to nephrotic syndrome. And how do you identify a child with hypovolemia? The symptoms could be in the form of abdominal pain, which is a very common symptom. And it need not be only peritonitis or gastritis. Hypovolemia itself could be the cause of pain. The child may present with vomiting, lethargy. Capillary refill may be prolonged. The child may have cold extremities, tachycardia, low volume pulses. The blood pressure may show a postural hypotension. So that is an important sign to manifest and to check if the child has a postural hypotension. So the way to demonstrate postural hypotension is that first make the child lie down, record the blood pressure, and then ask the child to sit. If there is a fall in the blood pressure by at least 10 millimeters of mercury from supine to sitting position, then this child could be having a postural hypotension, and which could be resulting from the hypovolemia. Then there are many bedside indices which you can make use of to identify whether these children have a hypovolemia or a normal volume status. So these could be in the form of hematocrit, a BUN to creatinine ratio more than 100 could be suggestive of hypovolemia. Fractional excretion of sodium, especially less than 1 or less than 0.5 could point to hypovolemia. There is another useful index called urine potassium index, where you measure urine potassium upon urine sodium plus potassium. And if it is more than 60%, then that also signifies hypovolemia. Rarely, you may also need to use ultrasonography to determine the inferior vena cava diameter. And if there is a collapsing IVC, then that also could be a sign of hypovolemia. So this child basically has a very low albumin, as we can see, 1.2, which is a very low albumin, a normal creatinine, and otherwise essentially normal parameters. When we calculate his urine potassium index, we find that it is 74, which is more than 60%, and that suggests that this could be an underfilled or a hypovolemic condition. And also as the FENA, which is very low, less than 0.5%. So all these parameters and the signs and symptoms point to a possible hypovolemia. So in a child who has hypovolemia, the first priority is to expand the intravascular volume by giving crystalloids or at certain times even IV albumin. So this child would benefit from a crystalloid or IV albumin infusion, but definitely this child is not a candidate to give diuretics. So even if you find the edema in this child, when you assess and if there is a hypovolemia, this child should never receive diuretics in this presentation. This child received crystalloids followed by IV albumin, and the edema resolved, and he was symptomatically better and then was discharged on oral prednisolone. The next presentation is that of a severe edema, which is also a common presentation and one of the common complications in nephrotic syndrome. A 2-year male child presents with periorbital puffiness and has generalized anasarca. He also has a decreased urine output and cough, cold, and fever, and has, unlike the first child who has a clear-cut evidence of hypovolemia, he doesn't have any hypovolemia. The capillary refill time is 2 seconds, the pulse volume is good, and there is no severe tachycardia. However, there is a 3 kg weight gain compared to the baseline, and all these parameters should be taken into account. The baseline weight has to be recorded, and since then, how much has been the weight gain? That gives an idea about how much is the volume overload or the extent of edema. So now the edema is a striking feature in most of the children with nephrotic syndrome, and it usually correlates with the degree of proteinuria that one would find on different parameters that one would assess, dipsticks or the sulfosalicylic acid, and it usually correlates with the grade of proteinuria. Now, we all know that the edema could be resulting from 2 major causes. One would be the underfill hypothesis, where the child basically has a low albumin, which leads to low colloidal osmotic pressure, and that causes effective hypovolemia leading to underfill. As a result, there are compensatory mechanisms activated like a renin, angiotensin, aldosterone, which leads to sodium water retention, and then that can perpetuate or increase the extent of edema. So this is the first 2 cases that we saw belong to the underfill category, where the child basically has hypovolemia or a hypoalbuminemia causing edema. As against this, we rarely can encounter conditions which are basically of a different nature, where there is some derangement in the renal function. For example, a glomerulonephritis, where a creatinine is elevated and has got some amount of renal insufficiency. And as a result of this, the child may retain a lot of sodium to begin with. So there may be a primary sodium retention, and this may result in overfill kind of a edema or a overfill kind of a volume status. So these children basically may present with hypertension, severe volume overload edema, and usually they may have some kind of a renal insufficiency. So whenever you have a child with edema, it is important to identify what category the child belongs to, because your further treatment would be different for both of these conditions. So there would be simple parameters to decide whether the child has an overfill or underfill. So you may have to have a creatinine, a serum albumin, a blood pressure, and based on these 3 parameters, you may be able to make a decision whether the child may be belonging to overfill or underfill. So if your creatinine is usually normal, if your albumin is very low, and if you have a blood pressure which is normal or slightly on the lower side, you may be fitting into the underfill category, as against the creatinine which is elevated, a serum albumin which is more than 2, and a child who has a hypertension may be belonging to the overfill category. So this child basically has a severe edema, no signs of hypovolemia, and this child basically again could be an underfilled state. So this child again could benefit from an IV albumin infusion. But now, to control the edema in this child who does not have hypovolemia, it could be safe to consider furosemide or Lasix. So this child basically received albumin and Lasix combination, and the edema improved. The child got better, and he was discharged on oral prednisolone. So it is important to take care of all these things before you decide to use albumin or diuretics. Now, what are the different measures to control edema? The first and the foremost thing to do is to cut down the dietary sodium, the salt content in the food, because that is the most important reason why a child may have increasing edema on follow-up. So first, you cut down the excess salt that a child may consume in the form of bread, biscuits, chips that the child may be consuming. Give him adequate nutrition. Usually, there is no need to restrict fluids severely unless the child shows brisk diuresis, and then you may think of restricting fluids. But otherwise, do not restrict fluids as to the first step, because it may lead to further problems like a thrombosis. Diuretics may be carefully chosen. The patients could be carefully chosen who could receive diuretics and who should not. IV albumin, as we saw, it could be used in those children who have hypoalbuminemia. Definitely avoid any nephrotoxic medications like non-steroidal anti-inflammatory or ACE inhibitors to begin with, without unless you have ruled out hypovolemia. Avoid any deep lines, because there could be a risk of deep vein thrombosis. In very severe conditions, when the edema is definitely resistant to all these medications, you may sometimes need to use ultrafiltration or some kind of dialysis. And there are some traditional measures like limb elevation, compression stockings, and head out water immersion, which is usually quite difficult to practice, but has been one of the measures mentioned. Sodium restriction, as we all know, would be a 35 milligram per kg per day, and fluid restriction that one need to sometimes resort to would be the oliguria level plus the urine output. So there are different food contents. The sodium content in the different foods that a child may consume could be belonging to any of these three categories, and you may have to counsel the parents to cut down the sodium content in the diet so as to control the edema and the hypertension. So sometimes we may have to use diuretics, and the diuretics, as we all know, could be belonging to different classes. So then we have the loop diuretics, the thiazides, the spironolactones, and the other diuretics like mannitol, and they act at different sites. For example, loop diuretics, as we know, would act at the thick ascending limb, and the thiazides would act on the distal tubule. And so many times we need to use combination of these diuretics to achieve a good control for the edema. These are the common dosages that we need to use for these different diuretics, and it's available in standard textbooks, and one may definitely refer to these. So whenever we have a child with hypovolemia or a child with edema, the first step would be to see for hypovolemia. If there is no hypovolemia and if the child has mild edema, the first thing to do is to restrict the sodium content in the salt. And if the child has a moderate to severe edema, we may proceed by using judicious use of diuretics in the form of oral furosemide. If required, we may add additional diuretics in the form of spironolactone. And if the child is further not improving, agents like metalozone, which are act on the proximal as well as distal tubule, could be added, hydrochlorothiazide, and sometimes even IV infusions of furosemide could be required. Very rarely, if the child does not respond, even IV albumin could be required, and rarely a dialysis could also be required to control the edema. If the child has hypovolemia, definitely crystalloids in the form of 10 to 20 ml per kg has to be given, and if not responding to that, even IV albumin could be required. Another common complication is acute kidney injury or acute renal failure that may be sometimes encountered in nephrotic syndrome. What are the common causes of acute renal failure? These are usually the first and foremost is hypovolemia. Sometimes if the edema is quite severe enough, it can cause interstitial edema within the kidney, and that itself can compromise the renal perfusion. There could be AKI resulting from nephrotoxicity. Many children receive diuretics. Sometimes in those children who are steroid dependent or steroid resistant, they may be on calcineurin inhibitors like cyclosporin tacrolimus, which are inherently nephrotoxic. Aminoglycosides, which are given for some certain infections, could be nephrotoxic, and non-steroidal anti-inflammatory, which are given often for the fever and pain conditions, could also be nephrotoxic. So it is very important to avoid all these nephrotoxic medications as far as possible. Sometimes there could be acute interstitial nephritis, a child who has been given some antibiotic reacts very badly and could develop an allergic reaction in the form of interstitial nephritis, which could result in AKI. There could be a hypovolemia resulting into hypertension, and it could lead to acute tubular necrosis. There could be urinary infection, sepsis, which could result in acute kidney injury. Abdominal compartment syndrome is also a very rare condition, but an important condition, which is found in those who have a severe ascites, and this ascites compromises the renal perfusion and can lead to AKI. Sometimes, rarely, there could be an ureteric calculus, which can lead to obstructive uropathy, and rarely one may also encounter a renal venous thrombosis. So these are all the common causes of acute kidney injury in a child with nephrotic syndrome, and one has to think of all these possible causes. A common condition, a 14-year-old girl who is a known case of nephrotic syndrome since several years and has a steroid-dependent pattern, has already been on levamisole, presents with relapse of nephrotic syndrome, and there has been a significant weight gain. She presents to ER with abdominal pain, vomiting since 1 day. Now, as we saw that abdominal pain could be a classical feature of hypovolemia, this child shows features of hypovolemia in the form of prolonged CRT and a postural hypotension. And when we do the investigations, the creatinine is just borderline elevated, maybe 0.8, but has a high hematocrit and a very low hemoglobin, a polycythemia and a hemoconcentration, and a very low albumin. So there is a setting for a hypovolemia. So what are the common causes? What could be the differential diagnosis that one may think of in this child? There could be hypovolemia. There could be a relapse causing some kind of an infection, peritonitis, steroid-induced gastritis as a cause for the abdominal pain, and rarely a venous thrombosis also could be suspected. So whenever you have an abdominal pain in a child with nephrotic syndrome, think of all these common causes. So now how do we proceed? This child definitely has a hypovolemia. So we need to give her fluids, which could be the choice could be colloids versus crystalloids. One would start with crystalloids and then proceed to colloids if required. The volume, as we usually give 10 to 20 ml per kg, would be the volume that the child may require. And at rarely one may need to use IV albumin. Then there could be a decision to use 5% versus 20%. We would see subsequently. So volume status, this child has a hemoconcentration, abdominal pain. The urine potassium gradient is more than 60, which is 80%. PENI is very low, and this is an underfilled condition. So this child basically receives a crystalloid infusion. Ceftriaxone is given initially until the infection is ruled out, and then the child felt better for a few hours. However, the abdominal pain recurred, and the child subsequently was found to have a rising creatinine. So 0.8, which was to begin with, rose to 1.4. And there was evidence of hyponatremia. So now this was basically a case of hypovolemia-induced AKI. So AKI is basically a common condition in children, and the incidence could be from anywhere from 3.3 to 8.5%. It's commonly seen in children who require hospitalization, and usually the sick children who get hospitalized could be having AKI, especially in those children who have a relapsing type of a presentation, and those children who have received some kind of a nephrotoxic agents. Even one dose sometimes could be enough to cause an acute kidney injury. Most of these children would resolve, the AKI would resolve, but may have a risk for a future CKD. And hence AKI is a very important condition which should not be missed and which should be treated adequately. So when this child who has a hypovolemia with mild edema, we decided to give 5% albumin. The abdominal pain resolved and the creatinine also normalized. And this child was subsequently discharged on prednisolone. So now the indication for using albumin could be hypovolemia or edema, or a child who has a pre-renal acute kidney injury. So any child who has an established renal failure should not receive IV albumin, but a child who has a pre-renal kind of hypovolemia could be a candidate for receiving albumin. So the albumin basically promotes water diuresis, and that's how it brings about control of edema and also improves the organ perfusion. So now we have the 5% albumin and the 20% albumin, and although it can be used interchangeably, there is a slight difference. A 5% usually is used as a volume expander in shock-like states, whereas a 20% is usually primarily used as an agent to control the edema. So this is a fine difference that one need to control, one need to think of. And we also know that this albumin which we give is not going to be there in the circulation for a very long period of time, as against the endogenous albumin, which is usually there for almost a month. The IV albumin which we give usually gets wasted out from the body within a matter of few hours, and hence IV albumin should not be used very regularly and only in selected situations. So the take-home messages for this part would be to have a bedside volume assessment, avoid unnecessary use of diuretics, take up a careful history and physical examination, rule out common complications, use cautious use of IV albumin, and supportory measures like dietary sodium restriction could be important. Another common situation would be a peritonitis, a 4-year-old boy who presents with abdominal distension, edema, abdominal pain, there is fever and few loose stools, and a CBC shows a polymorphonuclear leukocytosis and a 3+ proteinuria and no RBCs. So a child with nephrotic syndrome may present with a multitude of manifestations of infections. The common infections to consider could be peritonitis, pneumonia, cellulitis, sepsis, and chickenpox. So these are very common conditions which can at times be very severe and can also prove life-threatening. Peritonitis, as we know, could be most commonly because of the encapsulated organisms, and the way to diagnose peritonitis is a ascitic tap which demonstrates more than 100 WBCs, more than 50% neutrophils, and a culture or a latex agglutination assay could also help us in identifying the exact organism. And this needs to be treated with IV ceftriaxone or cephalosporins, or even penicillins in certain situations could be used. The other conditions, pneumonia, cellulitis, sepsis, and chickenpox also are important conditions, and they need to be treated promptly. So varicella especially could be a life-threatening condition, and the child will need IV acyclovirids or sometimes even a immunoglobulin to control these conditions. So this child basically underwent an ascitic tap and showed 250 WBCs, polymorphonuclear predominance, and pneumococcus was grown on the culture. This child was treated with ceftriaxone for 10 days, after which the symptoms improved, and the child was then restarted on prednisolone, and this child basically improved. So this was a case of a subacute bacterial peritonitis, and rarely could be life-threatening, needs proper treatment and prompt diagnosis. Another common complication is a thromboembolism. A 9-year-old girl who is a known case of steroid-sensitive nephrotic syndrome presents with a right-sided acute loin pain, so acute abdominal pain, has a nephrotic range proteinuria, a very low albumin, and ultrasonography which is done basically reveals nothing but CT abdomen picks up a right renal vein thrombosis. So now this is a very kind of a medical emergency, and this child needs a prompt treatment in the form of hydration and IV enoxaparin or a low molecular weight heparin. And this is basically given promptly, and it takes time for the thrombus to recanalize and needs a proper follow-up to see whether the thrombus has recanalized and whether the kidney is functioning properly. At times, you may also need to do a prothrombotic workup in the form of protein C, protein S, antithrombin 3 to see if the child has got some prothrombotic tendency. So there could be different ways in which the child may present with a thromboembolism, a kind of a squint, which could be a sign of an intracranial thrombosis, or there could be an extradural hematoma or any kind of a venous thrombosis. There could be a shiny appearing skin on the leg, which could be a suggestion of a deep venous thrombosis. There could be a finding of a renal vein thrombosis on a CT or an abdominal imaging that one may find, and suddenly sudden onset breathlessness that may develop in a child may be resulting from a pulmonary embolism. So thromboembolism is a very common complication, and especially in those children who receive diuretics in unsuitable settings, especially in a child who is hypovolemic, and hence the take-home message is that do not use diuretics unless you have made sure that the child does not have hypovolemia. Yeah, Dr. Pankaj, you may take on the next part.
Yeah. Thank you, Kiran. Now, Kiran has very well highlighted all the important complications. And I'm stating again, what can really kill patient in nephrotic syndrome who are steroid sensitive are their complications, whether it's infection, whether it's AKI, or it's a thromboembolic episode. So before we start on any treatment further, complications should be ruled out. So now we'll come to another difficult part of managing nephrotic, that is, how do we manage frequent relapses and dependent course? Next slide. Now, how do we define frequent relapses? 2 or more relapses in first 6 months after treatment of first episode of nephrotic, or more than 2, that is 3 or more in any 6 months during course of nephrotic, or 4 or more in a year during course of nephrotic. So more than 2 and 4 in 6 months or 1 year warrants it's a diagnosis as nephrotic frequent relapses. While for dependent, we need to have 2 consecutive relapses on alternate day or within 2 weeks of discontinuation. So just 1 episode after stopping steroid is not steroid dependent. There need to be two consecutive relapses before we label them as a dependent. And the last is steroid resistant, that is lack of complete remission despite 6 weeks of daily steroid. We'll come to steroid resistant afterwards. Now first we'll see how do we manage frequent relapses and steroid dependent. Next. Now when we see first time nephrotic syndrome during first episode, can we have subtle markers which can help us to pick up that probably this child may have frequent relapses in the futures? So what are those? If age of onset is below 3 years, if we are not able to induce remission at early initial immediately, that means in less than 2 weeks, if child has received corticosteroid of inadequate course, what we have said 3 months total, instead of that, if it was discontinued in between, the chances of frequent relapses are high. And if he relapses early, that is within 6 months of first episode, all these candidates are high risk for frequent relapses. 70 to 80% of kids relapse within 1 year, and almost 30 to 50% of the patient with nephrotic syndrome will have frequent relapses. Why are we so much worried of frequent relapses? Because every relapse will require steroid. Now, on one side, I said that almost 97 to 99% will be cured of the disease, but still we are so much worried of frequent relapses because mainly of steroids side effects and its toxicity. Next. Now, the first drug what generally everyone can prescribe in frequent relapses is prednisolone. So there is no role of deflazacort, which is very commonly used in adult nephrology. In pediatric, there are no significant study which support use of deflazacort, even if we want to continue steroid for longer duration. What is the rationale behind using long-term low-dose steroid? Why don't we use steroid as and when child relapse? Let's have every 3 monthly he relapse, give 1 month of course. So the cumulative dose of steroid and the toxicity of giving repeated courses of full dose steroid are more than using low dose alternate day steroid. So it is always preferable to use long-term low dose of alternate day steroid rather than repeating full dose of course for every relapse. We shall gradually taper the dose of prednisolone to 0.5 to 0.7 milligram per kg on alternate day, and that dose can be continued for 9 to 12 months. But if we are not able to bring down steroid to 0.7 milligram, it's a time that we need to add other steroid sparing agents to prevent toxicity. Generally, it has been shown that if we restrict dose to 0.5 to 0.7 milligram per kg, the risk of steroid toxicity is not very high. But whenever we are planning to give long-term steroid, we need close monitoring of blood pressure, monitor for hyperglycemia, and look for ophthalmic complications every 3 to 6 monthly. Look for posterior subcapsular cataract, as Kiran has already shown in his slides, and glaucoma. And if he's having relapses on this dose, or we cannot decrease the dose, it's time to refer, because here we need to add steroid sparing agents. Next. So what are the options we have? Before we see available option, now mesorabine, azathioprine, and chlorambucil, which was used previously, is no longer recommended because first two drugs does not have good efficacy and chlorambucil has significant toxicity. So these drugs are out of the list for treatment of nephrotic syndrome. So the drugs which we have available at handy are levamisole, cyclophosphamide, mycophenolate, calcineurin inhibitor that includes cyclosporine and tacrolimus, and injection rituximab. Now, every drug has different course, every drug has different side effect schedule. So levamisole is a good drug, but relatively efficacy, like almost 30 to 40% kids responds to levamisole. What I mean by response, that the frequency of relapses drops down significantly. But we see a lot of prescription where levamisole has been prescribed from first episode, or infrequent relapses has prescribed very erratically, like once in a week, twice a week. No, it should be given as an alternate day. Relatively safe drug. We need to monitor blood counts and SGPT level, because rarely it can come with leukopenia and transaminisemia. Cyclophosphamide is a very good drug, is known to induce long-term remission, but it's relatively toxic agent. It is known to cause alopecia. Almost most of the kids do have some form of alopecia, leukopenia, cystitis, and long-term complication of gonadal toxicity, which can cause sterility. If we don't use proper drug, we use very irrational high dose, it can even cause sterility. So the cumulative dose of cyclophosphamide should not go above 168 milligram per kg. And while monitoring, if TLC falls below 4,000, it's time to stop drug and reinitiate after TLC rises at a lower dose. Mycophenolate, it's a good drug, safe drug, and generally the side effects what we see in mycophenolate are abdominal pain, diarrhea, and nausea. So more of a GI upset. But again, this drug require monitoring for SGPT and TLC counts. Calcineurin inhibitor, both of these drugs are actually nephrotoxic agents, but they are very good when previous three agents do not work well. But again, they need to have close monitoring and better to be followed under pediatric nephrologist. And the new drug is rituximab. Here, 2 doses of injections are given at 1 week apart. The risk of serum sickness is significant in rituximab. So it's better to administer in hospital condition, and child should be observed for 24 hours. Next. Now we have so many drugs available. So which is the appropriate direction? Next. So now this slide shows how do we manage. First, start on alternate day prednisolone. Despite on that, child has frequent relapses. Now we need to consider next steroid sparing agents. Now before initiating steroid sparing agents, we need to assess, does child has complicated relapse? What do we mean by complicated relapse? Next. Complicated relapse means if child has any of these complications, hypovolemia, AKI requiring inpatient care, severe infection, here along with peritonitis and meningitis, even cellulitis is included. So cellulitis is also considered severe infection. And if child has any thromboembolic episode, this means these are complicated relapses. Here, we cannot use the milder drug like levamisole we need to use better drugs like mycophenolate or cyclophosphamide. Next, or if child has steroid toxicity in any of these form, hyperglycemia, short stature, obesity, ophthalmic complications, psychosis, so these kids also cannot be managed with levamisole. Here we need either mycophenolate or cyclophosphamide. So initial start with low dose steroid, then assess patient, and any of these complicating factors are not present, consider levamisole. If any of these are present, consider mycophenolate or cyclophosphamide. After giving these two drugs, out of these three, if we have tried two drugs and still child is not responding well, we can label it as a difficult to treat disease, and here calcineurin inhibitor can be used. So remember, CNI does not come in first line. It will be used only if previous 2-3 agents are not effective or child has side effects along with that, then only CNI comes in role. Wherein adult, CNI starts at very early age, and we do see a lot of patients starting on CNI even during frequent relapse course. Next. Now, these are the general guidelines, but while treating patient, treatment needs to be individualized. So what are the other points we need to consider? Suppose child had proteinuria during infection. Shall we start steroid? No. First, treat infection. After treatment of infection, reassess proteinuria, because many of the children, almost 30 to 40%, may go in spontaneous remission, and we don't need to start steroid. But if child has serious infection, we may need to add low dose stress dose steroid. We'll see that in next slides. Avoid long-term steroid in dependent patients or with significant steroid toxicity, because this warrants further steroid sparing agents. Avoid cyclophosphamide in a very young patient because they do not show adequate response, and at pubertal or post-pubertal age because the risk of gonadal toxicity is very high. MMF has better efficacy over levamisole, so in dependent patient prefer MMF, and CNI is more effective than MMF. So very young patient where MMF may not show satisfactory response, CNI can be used. Next. So amongst these agents, who is the better? So we have seen few of the profile, and next three. Immunosuppression is significant with mycophenolate and cyclophosphamide, and minimum with levamisole. Toxicity, minimal with levamisole and maximum with CNIs. And if we go cost, MMF and CNI are very costly. So many of the time, before selecting the agent, we need to take in consideration all of these agents, all of these factors. Next. But the good news is that whatever agent we use, if we treat adequately, we may have multiple relapses. We may need to use one after other agent. So as long as child is steroid sensitive, most of them, almost 98 to 99%, will go in remission and child will be cured of the disease. So this is the good news, but the agent should be used properly and adequately. Next. If child is on steroid for more than 2 weeks in last 1 year, and if child lands up with any serious infection, any operative stress, which may even include dental extraction, child should be given stress dose of steroid, because we are suspecting that hypothalamic pituitary axis will be suppressed because of this use of steroid. And prednisolone can be given 0.5 to 1 milligram per kg. And if child is on IV fluid and not taking orally, we can use hydrocortisone. This supports the period of stress, and the low dose of steroid sometimes induce remission, and the long-term use of steroid can be avoided. Next. Now, the last case, a 4-year girl who presented with generalized edema, no other atypical features. Urine protein was 4+ with PCR of 12, treated with prednisolone adequately, but after 6 weeks of treatment, urine protein is 2+, while urinary PCR is 1.2. So is it steroid resistant? Because proteinuria has decreased, edema has resolved, 4+ has come down to 2+. So is it steroid resistant, or shall we give methylprednisolone and reassess? No. The definition of resistant is, next slide, the lack of complete remission. Complete means proteinuria should completely resolve. Even 2+ is not acceptable. So proteinuria should resolve to trace or nil, and PCR should be normalized, then only we'll consider it as a remission. Otherwise, we'll label it as a steroid resistant, and there is no role of giving methylprednisolone as a pulse dosage, because it will further increase steroid toxicity and will not add any advantage in the management. And 50% of patients with nephrotic syndrome can have steroid resistant, and almost 30 to 50% may progress to end-stage kidney disease within 10 years. This rate is more common with FSGS. There are multiple etiologies along with primary idiopathic. It can be hereditary, where we see single gene mutation. Many of the infection, drugs, and hyperfiltration because of decreased glomerular number can also progress to FSGS and end-stage kidney disease or steroid resistant. Next slide. So when do you subject child to kidney biopsy? If at onset, child presents with gross hematuria, child has persistent microscopic hematuria, acute kidney injury which is not explained by hypovolemia, extrarenal features, or low C3, all these requires kidney biopsy. If it is a steroid resistant nephrotic, we shall biopsy first before considering CNI or other agents. And if it is a steroid dependent case, it is advised to get kidney biopsy before starting CNI. So where is that age criteria gone? Initially, if we remember during initial phases, we used to say child less than 1 year and more than 8 to 12 years should have kidney biopsy. But now it has been shown that age per se is not a criteria for biopsy. Even if child present in adolescent age with first episode of nephrotic, a trial of steroid should be given before trying for biopsy. And in biopsy, particularly in steroid resistant cases, FSGS is the leading cause, almost 47 to 48%, followed by minimal change disease, and then rest of the other causes. So that's why in steroid resistant, biopsy is mandatory, while in steroid sensitive, treat with steroid and then decide about biopsy if child does not respond well. Next slide. So when we shall not do biopsy. These are, and we need to go for genetic test rather than doing biopsy. Next slide. Young infants with nephrotic syndrome. Young infant with nephrotic syndrome. That means if child is around 3 to 4 months, biopsy does not have role. Genetic test will be important. Older infants with steroid resistant. So child is somewhere around 9 months. We have started prednisolone, and if he has not responded, here again, the risk of single gene mutation is high, almost 75%. So biopsy will not take precedence here, genetic test will take. If it's a steroid resistant with familial disease, so in family, there are other cases of steroid resistant or syndromic presentation. All these cases should be subjected to genetic test first before considering biopsy. Next slide. So single gene defects are very common in a child presenting as a nephrotic syndrome below 1 year of age. With age, the incidence drops down, even if it is a steroid resistant, to 18%. So from 70%, it drops to 18% by 12 years of age. 50% of kids who has family history of SRNS, we are going to find some or other genetic defect. And Indian cohort had shown almost 25 to 30% may have genetic defect in steroid resistant nephrotic syndrome, where NPHS 1-2 tops the list of genetic defect. Next. So the treatment, the first line drug is calcineurin inhibitor, that is cyclosporin and tacrolimus. Here drug level monitoring is very important, because we need to maintain drug level at optimum before we assess good response or before we label it that this is a CNI resistant nephrotic syndrome. Second line drug is rituximab. If child has not responded well to CNI, we can consider rituximab. If child is not affording, child is very poor, we can consider injectable cyclophosphamide. And if child has low GFR, rising creatinine, or CNI resistant, we can consider mycophenolate. Sometimes we use mycophenolate along with CNI, so that if child has showed partial response to CNI, adding mycophenolate can help child. Next. But if child is resistant to CNI, before doing further immunosuppression, whether it's a mycophenolate or rituximab, it's better to look for genetic defect, because if we find single gene mutation, there is no role of further immunosuppression, because they are not going to respond whatever combination we use. and here child need to shift on conservative management, prepare for CKD and future renal transplant. Next. Now, in steroid-resistant nephrotic syndrome, supportive care do play very important role. In steroid-responsive nephrotic syndrome, once child has gone in remission, these complications just evaporate. And with time, if steroid has been stopped for 6 months, even the side effects associated with steroid also will improve. But in steroid resistant, where we are end up with giving steroid for long duration, we need to have a close monitoring on hypertension. Look for any complication like thromboembolism, AKI. Pay good attention to bone health. So when child is on long-term steroid, he need to be on vitamin D supplements as well as calcium. Look for hypothyroidism. If TSH is more than 10, we need to start on thyroxine supplement also, and assess for stress dose of steroid whenever child lands up with severe infection. Kiran, I hand over mic for last.
That's really the last case for today's presentation. And as we saw that Dr. Pankaj mentioned that genetic mutations may at times be the cause for the nephrotic syndrome. So congenital nephrotic syndrome is such an entity where the child does not require steroids or would basically not respond to steroids, as the cause is basically because of some genetic mutations or certain times some infections. So we'll see a case, a 2-month-old male child who presents with severe generalized edema. There is a normal creatinine, albumin is very low, and the child presents with nephrotic range proteinuria. So in a typical situation that we would find in an older child, this would look like a typical onset nephrotic syndrome. But the age of presentation being 2 months is definitely much younger than 1 year, and especially below 3 months of this is a simple important indicator that this is going to be not a typical nephrotic syndrome, and this is going to be a congenital or an infantile nephrotic syndrome. So congenital nephrotic syndrome, basically, if it is the onset is below 3 months of age, and infantile onset, especially between 3 months to 1 year. So whenever you have any child who presents with nephrotic syndrome below 1 year of age, definitely think of some genetic causes that one may have, and you may have to send a genetic testing in these subset of children. So now this child basically had a normal blood pressure, no dysmorphism. There was mild hepatomegaly. As a part of the workup, we sent a torch titers and the CMV PCR came positive. The child had intracranial calcification, and this was diagnosed as a congenital nephrotic syndrome due to congenital CMV infection. So torch infections are another important cause for the congenital nephrotic syndrome. But many times what we find is that even after treating the torch infections, as we did in this child, we treated this child for the congenital CMV with valganciclovir. However, even after adequately treating, the proteinuria persisted, and the child required multiple IV albumin infusions, despite which the proteinuria did not subside completely. And as a result, we find this common situation that when you do a torch test, there may be some parameter coming positive, either a congenital CMV toxoplasmosis, but on the background of that as well, you may have a genetic mutation which may be positive. As we found in this child basically had an NPHS1 homozygous mutation, and which was the basic cause of the congenital nephrotic syndrome. And if we see the cases with congenital nephrotic syndrome, it has been found that more than 80% of cases, or almost 90 to 100% of cases, may also have some kind of a genetic mutations in the podocyte proteins. So NPHS1, which is basically a podocyte protein, when it is deficient or homozygously absent, it leads to alteration in the glomerular basement membrane and leads to massive proteinuria. So the way to treat this condition is basically giving ACE inhibitors, which basically help in reducing the proteinuria. The enalapril or the lisinopril, these are the agents which are to be used. And in this child, after starting ACE inhibitors in a higher dose, it helped to control the edema, although the proteinuria did not stop completely. The child continues to have a proteinuria. And initially, the child also had hypothyroidism, for which the child required thyroxine supplementation, which is basically important to ensure the normal neurological development. At 5 years now, the child has reached 5 years and there is no edema per se, normal creatinine, but still has a nephrotic range proteinuria. And just with the enalapril or ACE inhibitor, we were able to control the edema. So now this child, although has a normal creatinine, but this continued proteinuria is going to be a cause of concern, as this continued proteinuria is ultimately going to lead to focal segmental glomerulosclerosis or a global glomerulosclerosis, and eventually this child may land into a chronic kidney disease. So this child basically requires a regular renal evaluation, and at some point of time, the child may require need for dialysis or a transplantation. So important point to consider here is that basically the congenital nephrotic syndrome could be because of the mutations. There could be secondary causes, but now in this situation, you should always send a genetic testing because there may be some genetic mutation which may be present. And especially if this child lands into a end-stage kidney disease, and when you are contemplating a transplantation, it is important to be aware of the genetic mutations that the child may be harboring. And I think that's the take-home message that nephrotic syndrome is a common condition, easy to treat, and most of the times the child may recover completely. But there may be certain situations where you may land into complications because of the disease or because of the treatment per se. And one may have to pay a detailed attention to the history that the child may present with and even the physical findings. Dr. Pankaj, would you like to add anything?
No, you have covered well.
So I think that concludes. We can take some questions if we have.
Okay, excellent session so far, Dr. Pankaj and Dr. Sathe, sir. I thought about to ask some questions, but then as things go advanced, automatically everything comes. Like suppose I thought of asking about kidney biopsy, the question was asked. About congenital nephrotic syndrome, it was also asked. Well, you have covered all these ones. I have one question specifically after COVID or during COVID. Do you see rise in the number of nephrotic cases?
Not exactly.
Both of you, please.
Yeah. No, nothing significant rise, particularly rise in nephrotic syndrome per se. Yes, there has been some rise in glomerular sort of nephritis. Those were also during just COVID period. After that, I think it's back to what it was before routine.
Yeah.
Dr. Kiran,
Yes, I agree. So we are not seeing any increase in the nephrotics, but there could be some glomerular nephritis. So post-infectious GN that sometimes may be encountered.
Okay. So what about like thromboembolic episodes happening during the patient? Because some of the pediatricians do add certain like antithrombolytic or something like medicines particularly. So what is your thought on this part particularly, or blood thinners to be added?
No,
So
there is
basically,
no,
Kiran.
In a child who has basically hypovolemia, the first thing to avoid thromboembolism is the first important thing is to avoid diuretics, give adequate hydration, and avoid any thing that may precipitate a thrombosis. So I think the prevention is always better than cure. But even then, when you land into complication of a thrombosis, the first thing that you would be requiring is adequate hydration, and then think of these heparin agents which may be required. So thromboembolism is usually a medical emergency and needs prompt treatment and diagnosis.
Yeah, Samir, there is no clear-cut guidelines whether we shall add any blood thinners. Only if child has previous history of thromboembolic episode and a child present with relapse, and maybe if albumin is less than 1.5, we may consider, but these are not as a recommendation per se. So there is nothing like preventive blood thinners in nephrotic syndrome.
Yeah.
Okay. What about checking the urine daily morning, like districts, like we do it in the patients with a nephrotic syndrome for few days, but some pediatricians or some nephrologists ask them to do it periodically and some ask to do every day, 365 days. What are your thought process on this part?
I think daily would be the ideal, but even if you don't do daily, at least once or twice in a week would be important, and especially during any infection. So any viral infection, that is the time when you should definitely do it on a daily basis. But definitely at least once or twice in a week would be important.
So when child is in relapse, definitely. When
Yes,
child has gone
true. I'm talking about general aspect.
Yeah.
Like
So
these
now,
are the very less costly or like this ones, because treatment to continue in the tertiary care hospital, it will cost a lot of money.
yeah, so there is a thought process that we can consider intermittent urine streaks monitoring even if child has gone in remission, because we suspect maximum relapses within 1 year. So maybe up to 1 year they can do, but advising them daily becomes sort of, parents are getting so much obsessed with that. So maybe twice or thrice a week should be sufficient.
Yeah, if we look at the cost of the dipstick, it is not much really.
Yeah.
500 rupees you get for 100 strips. So, roughly 5 rupees per strip. So even if you want to do some economy, you can even cut the strip into 2 and, use one strip, twice. So I think, but dipstick definitely helps you in picking up a relapse early.
Early.
As we know, suddenly you may realize that the child has a 3+ proteinuria, and if you have not done in a long while, the child may suddenly the cost of the dipstick versus the cost of treatment, and the cost of the treatment is basically using the steroids in the full dose again. So I think definitely dipstick usage is a better way to prevent from going into the 3+ proteinuria all of a sudden. So I think on a weekly basis, definitely it would be a good idea to do the testing.
Dr. Pankaj, many patients we see come with the hypertension during the course of the hospitalizations or when they are at home. What will the best drug of choice in such patients of nephrotic syndrome?
In
Like
nephrotic, if in nephrotic syndrome, ACE inhibitors and ARBs will be the drug of choice for hypertension because it has dual advantage. One is blood pressure control, and also it decreases proteinuria. So as far as creatinine is normal, ACE inhibitors and ARBs remains drug of choice. But when you start ACE inhibitors and ARBs, make sure that we repeat creatinine and potassium after 5 to 7 days, because ACE inhibitors are known to drop GFR by 30%. So it is better to monitor these kids, but drug of choice are ACE or ARBs.
Yeah, so just one word of caution would be if a child has a frank relapse and in hypovolemia, that time you may avoid ACE inhibitor maybe. Dr. Pankaj, am I right? Because that could be the setting for a acute kidney injury. So you may first try to improve the hydration and then it would be safer. But definitely, as Dr. Pankaj mentioned, do a creatinine just to make sure that you are not causing problems by starting that. Otherwise, a calcium channel blocker could be a safe agent to start initially when the child comes with a severe relapse. And then later on, once the child is stable enough but continues to be hypertensive, ACE inhibitor definitely is a agent of choice.
Okay. One more question was on the Mantoux test. Like you are very skeptical, Dr. Pankaj. But if you see the people who do tuberculosis experts, they always say nowadays that Mantoux test has lost its potential because many of the patients has taken the vaccine and they can have positive reactions. And many times, sometimes patients are very severe cases of tuberculosis and they have Mantoux comes negative.
Yes,
so considering all this, how you will say now that we should go particularly with this one?
This is very debated topic. Frankly, we don't have scientific conclusion to it. What I have said are the guidelines. Basically, there are a lot of pitfalls with Mantoux. Already Nephrotic is a T-cell depleted system. So there is already depletion of T-cell. So Mantoux may not come positive also despite that. But if we have positive, what we are worried that steroid may flare up indolent course of tuberculosis. So these are the present guidelines. But on the contrary, when we treat pulmonary tuberculosis with empyema or any serious tuberculosis, actually we add on steroid as a treatment part of steroid. Yes, there are a lot of gray zones about Mantoux and about steroid during tuberculosis, but present guidelines, they have mentioned that let us wait for 2 weeks before considering steroid.
What about the albumin to start with, apart from steroids? Many of times, enthusiastic pediatricians I have seen, particularly those are intensive care specialists, they tend to go towards the albumin. They thought they have seen good results. What is your thoughts on that part? Both, I asked this question to both of you.
See, the albumin is not drug for treatment of nephrotic syndrome. What is going to treat edema and cure edema are steroid. All these other agents, whether we use diuretics, albumin, these are supportive measure, and supportive measures should be used only when indicated. Now, in nephrotic syndrome, like Kiran has said, there are both groups. One is which has underfill and overfill. So in overfill patient, we administer albumin. We are pushing child towards volume overload. And again, it is a blood-related product. So why do we want to expose the kid with all the diseases which can be transmitted through blood-related, which we may not have diagnosed yet? So on one side, there is a risk of side effects, complication. And on the other side, there is no advantage other than cosmetic benefit. Parents and pediatrician will be happy that edema has resolved. Unless child has clear-cut indications where it's a severe edema or hypovolemia, maybe we can consider albumin. Otherwise, asymptomatic edema, asymptomatic means the edema which is not troubling the child, may not require albumin at all.
Totally agree.
Okay. Dr. Nune, you have any questions with you?
Samir, there are 2 questions on chat. One was about
You can go ahead with.
there was
What are the questions? You can directly answer those, please.
Two questions are there, sir.
Yeah, please ask.
I'm just finding for it.
One is, should we do investigations before withdrawing the treatment?
Before withdrawing treatment means before stopping prednisolone at the end of course.
Yeah.
Investigations, blood lab tests are not required. What we require is only urine albumin. Even if we don't need urine protein creatinine ratio to document that child has been, as far as 3 urine albumin has been nil or trace and which has been maintained till 3 months of course, I don't think we need any further investigation. No need to reconfirm whether cholesterol has returned back to normal.
Okay.
Kiran, you want to add something?
Yeah, I totally agree. So it's basically bedside diagnosis and bedside monitoring. It's the investigations are only during the relapse that you want to, before starting steroids. Sometimes there may be a confusion. It's dipstick may show 1+, and you're not very sure whether there is a proteinuria or not. At that point of time, you may do a urine protein creatinine ratio to quantify, because that's a very common scenario that a dipstick may show 2+, 3+, and you are tempted to start steroids, but you want to be sure that the child really requires a full dose steroids. So sometimes even a short course of stress dose of steroids like a 0.5 milligram per kg per day would suffice. So in that situation, a protein creatinine ratio could be helpful to decide whether a full dose is required or not. So I think, but otherwise, investigations per se before stopping steroids are not required.
Okay.
So last question to both of you. How you will feel like a patient seen by the pediatrician versus patient seen by pediatric nephrologist? The first time they comes to the hospital.
Sir, Samir, your first question is how will you feel? Pura lagega yaar.
No, miss, like in the sense, like, see, the question is like, because we have seen many times both the sides actually happening. Because pediatrician competition miss the diagnosis, overdiagnose, underdiagnose, undertreat, overtreat, all types of things that happen. So my suggestion always, when a patient comes to me first time, I always do workup and at least send once to the nephrologist, pediatrics, to get his opinion. And then again, if everything is stable, he can refer us to back. But in some cases, really the case gets haywire and we need to be already seen only by the nephrologist. That's what I feel the way it should be. What are your thought process then? Rajesh, what do you do? Patient comes to with nephrotic syndromes.
Sir, I generally do the investigation and refer to Dr. Pankaj as he is visiting doctor here.
I think the only thing that the pediatrician may think of doing is that evaluate properly, and if the child does not require medications like diuretics, because that is a usual way that a child may lead into complications. So I think adequate hydration, avoid diuretics when it is not required, and I think regular monitoring. So I think these 3 things, if one pays attention.
Actually, Samir, it is very difficult for every pediatrician to refer to pediatric nephrologists because we don't have pediatric nephrologists everywhere. So I think first episode, as far as we have evaluated thoroughly, we are sure of the diagnosis. We can start steroid. Maybe as you said, at least one referral will be recommended. It is not only for deciding adequacy of treatment, even proper counseling. Because many of the times, so many questions they come up with, and we may not be able to address everything in our routine general pediatric busy OPD. So maybe for a detailed counseling and initial assessment, maybe once. But first episode and infrequent relapsers can be well managed at periphery. Because it's okay, in Mumbai we have a lot of people. But if we see in our area, like almost in 8-10 districts, there are hardly one pediatric nephrologist. So it is difficult for patients also to reach every time to a pediatric nephrologist. So as far as it's infrequent relapses, and we know the clear, and the course of steroid is not very difficult. It has been so well mentioned by most of our IAP guidelines. So there should not be very difficult unless child has some complications. As Kiran has pointed out, any of these complications, definitely I will suggest help of pediatric nephrologist shall be done. But for a simple relapse, it can be managed at every pediatric center.
There is one more question comes. Should we continue treatment if urine protein is negative and urine protein creatinine ratio is raised? I don't know what exactly they want to ask, but that was the question held here by Dr. Jitendra Gandhi. Dr. Jitendra, are you there?
Yes, sir. See, sometimes urine routine is not very quantification test. It's a semi-quantitative test. So if child is on diuretic, if child is drinking more of a fluid, it may show that urine albumin may be trace. Nil is little unlikely. Generally, it will show somewhere around 1+ if PCR is positive. But in that scenario, whenever we have quantified, then PCR take importance. If PCR protein creatinine ratio is elevated, definitely, but it is very rare condition that you will have urine albumin nil and PCR positive.
So, Dr. Rajesh Dune, should we conclude this one now, or any other questions there?
So I would like to thank the organizers for giving us. It was a nice interaction. Thank you.
Thanks, Dr. Kiran.
Thank you, sir.
Thank you. Thank you.
So we'll finish the program here. Before that, I will just once again thanks Dr. Sandeep Kadu sir, who is the forensic expert on the MHS, today's current MMC observer for today, for staying with us and then giving us the opportunity for this to continue on this program on MahaIP YouTube Live as well as on the Zoom programs. So thanks to him. Thanks Pankaj sir and Kiran sir for having excellent talk and try to reduce all the doubts. If anybody has any other doubts, you can ask and go for them. I will send the link to the people and their phone numbers and email address if required. So thanks Kiran and Pankaj for this exclusive webinar what we've done today. And we are so happy that people have learned a lot today. As usual, we are thankful to our President, Dr. R.D. Patil sir, and Secretary, Dr. Amol Pawar sir, for giving this opportunity to me and Dr. Nune to conduct and host this program for today. And background people, a lot of people are there, Dr. Pallavi, Dr. Raut, Dr. Neha Singh, Dr. Jadhav. We are thankful to all of you for this program what you done. So thanks everyone, and we'll stop here. Stop recording please now.